Okay, our number two, we're going to do CNS infections now. A lot of integration here with micro. We got bacterial infections of the brain, we got viral, fungal, and prion diseases. And of course, we can affect the outer covering, that's meningitis, or we can affect the inside of the brain, that is called encephalitis. Now, obviously, I don't want anything in my brain except for knowledge and pleasure. That's the only thing I want in my brain. So meningitis is bad, encephalitis is even worse. And obviously, since they're next to each other, meningitis often can lead to encephalitis if it's untreated. So very important to go through these. Now let's start out with acute aseptic. Now when I say aseptic, that means virus. That's what it means. Aseptic meningitis is a viral meningitis. Yeah, so most of the time it's viral, and 80% of those viruses are going to be the enterovirus family. So things like Coxsackie and Coxsackie and echovirus are the two most frequent. Now, you can also have other viruses, like for instance, herpes simplex type 2. If you're doing certain activities, you could get to type 2. Remember, type 1 is above the waist, type 2 is below. Could potentially go to your brain. You can get meningitis. Not very common, but it certainly can occur. Most common, enterovirus. Now, how do you kill a virus? Lymphocytes infiltrating the leptomeninges. So we're going to see a lymphocytosis here. Now, if there's inflammation of my meninges, am I going to get irritation, meaning a stiff neck? Yeah, you're going to get a stiff neck. Am I going to get photophobia? Yeah. Am I going to get a fever? Yeah, but low grade. Low grade. Viruses are low-grade fever. Bacterial is going to be high-grade fever, bacterial meningitis. Could I go unconscious from an infection in my brain? Absolutely. You can get altered consciousness, you can pass out, you can go comatose, you can go into coma. But the good news is viruses usually come on their own and usually go on their own. So these are usually self-limited, and we just treat them symptomatically. Now, obviously, if it extends into the brain and becomes encephalitis, that is very bad. And that will often occur if patients are immunocompromised. That's when it often extends into the brain itself. But as long as it's limited to the meninges, it usually goes away on its own. If you don't believe me, ask Brad Pitt. Brad Pitt came into Cedars with a headache, photophobia, and a stiff neck. And he was diagnosed with, I think it was Coxsackie, I can't remember exactly, but one of the enteroviruses. He had enterovirus meningitis, and he's fine. All right, he's getting divorced. But in terms of his health is fine. Although maybe he's not healthy. He's getting divorced, losing his kids. But otherwise, he's fine. But yeah, meningitis usually goes away. Now, encephalitis, different story. Because of the brain, it's bad. Now, what are you going to see if you do a lumbar puncture, a spinal tap? You're going to see lymphocytes. Lymphocytes in the CSF, we give it a fancy term. We call it pleocytosis when there's lots of lymphocytes, lots of white cells in the CSF. Now, protein is going to go up because of the inflammation, and that's going to track water. So you can get slight increases in pressure. And of course, you're going to have near normal glucose. Why? Because viruses are not living. They don't eat stuff. Viruses have to go into your cell, insert themselves in your DNA, and then replicate themselves. They don't eat anything. So glucose level is usually close to normal, as opposed to bacterial. Bacteria is going to eat up glucose. Mycobacterium, fungus, any kind of living organism, glucose usually drops. Okay, but this is usually near normal glucose because not much inflammation and the viruses are hungry. All right, now let's take a look at this brain. We're looking at the surface. Notice here, over here, I can see nice gyri, and the space in between is the sulci. So gyri and sulci looks good over here. But in this area, it looks creamy white, doesn't it? Creamy white? Yeah, this is called an exuding. This is pus. You got pus on your brain. You got pus on your brain. That is called a purulent meningitis. This is due to bacteria. So pretty easy to show this picture because the meninges are becoming opaque. I can't really see the gyri and sulci beneath this because of all this creamy exudate, this pus. Okay. Now, of course, gram stains are kind of a giveaway. Whenever you do a CSF, you want to do a culture in gram stain if you think it's meningitis. Now, gram stain is 3 points. I like 3 points and I cannot lie. Those other dots can't deny. When a question walks in with an ABD stem and a buzzword in my face, I get sprung. I I love those questions with short vignettes and buzzwords. The only problem is on the USMLE, they're getting less and less common. They're trying to make the questions longer and longer to simulate real life. In real life, you get lots of values that may or may not be important, and you have to kind of sift through them to see what's important, what's not important. So unfortunately, the questions on step one are becoming longer and longer. But that's okay. When they give you the short ones with the buzzwords, I love those. And this is a classic one. If you give me the gram stain of the CSF, I need to be able to interpret gram stain pretty easily. So if we take a look at these organisms, by the way, this is a neutrophil with a segmented nucleus, right? Neutrophil. Here's another neutrophil with a segmented nucleus, another neutrophil. So we see bacteria with neutrophils. Okay, this is purulent, no doubt about that. But notice, it's purple, almost black, right? That's gram positive. And then when I see two of them together, that's a diplococci. So gram-positive diplococcus, you definitely want to think about strep pneumo. Now, if they change the color and made it red, like this color here, if I made it red suddenly, then it would become a gram-negative diplococci. And then I want to think about Neisseria meningitis, Neisseria. So very important to know your gram stains because they're kind of easy. You should know gram-positive versus gram-negative, pretty easy. All right, now this is called acute pyogenic. There's pus on your brain. So when we saw the brain, you've got something on it, you've got pus. So basically you have a pussy brain. You got something on your brain. So this is due to bacteria. Now, for newborns, you just was born from mama's birth canal, you want to think about group B strep, which is strep agalactia. That's the number one for newborn babies with meningitis. Number two, you want to think about E. coli, again from mama's birth canal. And then number three, you want to think about Listeria monocytogenes. So I'm going to put that arrow here because Listeria affects the very old and the newborns. That's who gets, it's got the tumbling motility. So that's number three for newborns. Again, group B strep is the most common. We should look for it. When a woman is pregnant, we want to do cultures and look for this because if the woman has it during the pregnancy, we can treat it, and therefore it won't be there when the baby gets delivered. So we can treat it and prevent this. So this is very important. We know these common organisms. Now for children, we used to see a lot of H flu, right? But now because of the Haemophilus influenza B vaccine, we basically wiped it out. That's so cool. We wiped it out. Now, again, if they say the patient came from another country, they didn't get vaccinated, the parents refused the vaccines, then you can still see Haemophilus influenza B. But again, if they've been vaccinated, you're not going to get that. We'll basically wipe that bug out in this age group. Now, what about adolescents and young adults? Well, you're all going to live together in the dorms. You're going to live together in the barracks. You're going to live together. Well, when young people live together, saliva goes flying. And that's how you transmit Neisseria. Neisseria meningitis goes to the brain, and you get Neisseria. Now, do you remember the classic pattern in medicine? If you have untreated Neisseria meningitis, you're now going to get septic. When you're septic, you're going to get hypotensive. You're also going to get tissue injury, and that's going to lead to DIC. So let's repeat. When you have Neisseria meningitis untreated, you're going to get septic, your blood pressure is going to drop, and you're going to start clotting because you get DIC. So the combination of the clotting plus the low blood pressure causes acute infarction, hemorrhagically, of the adrenals. They both infarct acutely, so that's called acute adrenal insufficiency or Waterhouse-Friderichsen syndrome. This is a classic pattern in medicine. So because of your pussy brain, this infection leads to DIC and low blood pressure, and that's what leads to infarction. Basically, it's the veins. The veins of the adrenal get clogged up with clots. And so it's a hemorrhagic infarct of the adrenals. And this occurs usually with meningococcal, but also sometimes strep pneumo can also do it too. All right, now the elderly and adults too, strep pneumo is very common. And then older who are eating dairy, they can get Listeria monocytogenes. That's on with the tumbling motility. So Listeria is the very young and the very old. It's got the tumbling motility. It's like the MacGyver of bacteria because it stays intracellular. So only mononuclear lymphocytes can get it. Neutrophils can't get it. So listeria, that's like what monocytosis, you need lymphocytes to kill it. It's intracellular. And it's like MacGyver because it takes your cells' actin filaments and it designs a rocket. And it jets from one cell to the neighboring cell. Man, it's like MacGyver. It takes your actin and builds a rocket. Well, you guys are too young to know MacGyver, but if you ever see MacGyver, that guy can make an atomic bomb out of a pack of gum and a toothpick. Yeah, it was amazing. So these are the bugs you want to think of based on the different ages. Now, obviously, culture and gram staining is also very helpful too. But just based on the age, you should have an idea of what you should cover. Now, as I showed you, there's opaque meninges because of the neutrophil infiltrate. And of course, this is going to increase the pressure. I'm going to see headache. I'm going to see photophobia, very stiff neck, and irritability. I'm going to see a clouding of the consciousness. I go unconscious, get stiff necks. And of course, if I do a spinal tap, the CSF, it's going to show me really high pressure because lots of proteins are leaking out. So this is got one of the highest opening pressures. When you put the needle in, pressure goes way up when that fluid comes out. And of course, you can have purulent CSF with lots of neutrophils high, proteins really high, and glucose is really low because the bacteria eat it all up. So glucose is really low compared to your serum glucose. All right, now you can also what's called chronic bacterial meningoencephalitis, so meninges going into the brain. This is usually going to occur in people who have atypical bacterial infections. It's not usually routine bacteria. So things like TB, things like neurosyphilis, things like Lyme's disease, it's these atypical bugs that seem to cause this chronic problems. Now, tuberculosis, we know it starts in the lung, and then it can spread. It can spread. Now, what commonplace is the meninges. So you're going to get a meningoencephalitis, inflammation. Now, you can also get large caseating granulomas. They're so big, they look like a tumor. So we call it a tuberculoma. It's just a giant caseating granuloma. That's all it is. And we usually see this, by the way, at the base of the brain because of gravity. A lot of this is at the base of the brain. So you'll see these large, big lesions of granulomas basically invading the brain. That's a tuberculoma. Now, one of the most serious complications of tuberculosis is how is caseous necrosis going to heal? It's going to heal with scarring. So this is going to cause scarring of the arachnoid granulations. Remember, in the center to absorb the CSF, we have the arachnoid granulations. Well, unfortunately, they get all scarred up. They don't absorb. And now you'll get hydrocephalus, right? So this will be a communicating form of hydrocephalus. You can get there, but it just can't get absorbed. Communicating hydrocephalus, pressure goes up, and that's never a good thing. All right, now neurosyphilis, this is only going to occur if you have tertiary syphilis. So you have to have syphilis untreated, it's got to be tertiary. It's not very common in the United States. We don't see much syphilis, and if we do, we treat it. We don't wait for you to get tertiary. But it will occur in about 10% of patients with untreated tertiary syphilis. So not all patients, but 10% will make it that far. Now this is going to cause a meningovascular neurosyphilis. That's one form. This is going to cause a chronic meningitis with lots of vascular gummas. The gum is a $10 word for a mass lesion, which is full of plasma cells. Now always remember, syphilis is going to have plasma cells. Do you remember you diagnose it with VDRL and FTA? Those are looking for antibodies, right? Well, plasma cells make antibodies. So syphilis always has a lot of plasma cells making lots of antibodies. And they form what's called gummas after a while. Now you can also get the paretic neurosyphilis form as well. This is when you get not just meningitis involvement, but parenchyma involvement. This can give you a mood alteration, so you can get these delusions of grandeur. I think I have that all the time. I'm a legend in my own mind. Yeah, that's called a delusion of grandeur. Unfortunately, though, eventually you'll get severe dementia and you basically go insane. Yeah, so this is, unfortunately, in the past, this was one of the reasons people went insane. They go visit prostitutes, they get syphilis, they didn't go to the doctor, and they wound up going insane. Crazy, insane in the membrane. Now, another form that's very testable is TB's dorsalis. TB's dorsalis. This is when you get dorsal root infection and you damage the posterior columns. So if you remember your spinal cord, so in the back here, these posterior columns, they're the ones who are going to get damaged. And that's for proprioception, that's for position sense. So it's going to be a lot of sensory problems here. Now, question, if I don't know the position of my joint, you think I might step wrong and twist my ankle? You think I might damage joints frequently because I don't know the position my extremities are in? Yeah. When you damage a joint because you couldn't feel, that's called a Charcot joint. There's a $10 word for a joint that got damaged because I couldn't feel my position sense. So tabes dorsalis, very interesting if you remember those posterior columns. All right, now what about Lyme's disease? Well, I sent you a song on that. I can resend it to you if you didn't get it. But very interesting disease, and they're testing it quite a bit. And we're seeing it quite often because the deer population is making a big comeback. So because of all the deers, this is transmitted via the deer tick, the ixoide species, so a lot of people are getting Borrelia burgdorferi. In fact, a lot of celebrities too. A lot of celebrities have been getting. Do you remember Avril Lavigne? Avril Lavigne, she had Lyme's disease. So yeah, so it's a lot of people getting it. So Lyme's. Now, unfortunately, if you get it initially, you should see the target rash. You should treat with doxycycline. But longer term, if it's untreated, well, this can affect your joints. You get a lot of arthritis, and it can affect your brain and your heart. So I want you for arthritis. In the heart, they often get heart block. It's one of the most common heart lesions. And in the brain, they usually get either aseptic meningitis or more likely bilateral Bell's palsy, 7 cranial nerve palsies bilaterally. So that's very common. But again, Lyme's can cause any neurologic problem. I've seen encephalitis from it. I've seen meningitis from it, aseptic meningitis. I've seen many different types of neural lesions. Okay, it's kind of a naughty thing to get in your brain. Not good. All right, now let's talk about CSF findings. They're kind of like giveaways. It's like free points when they give us the CSF finding. Okay, now in your brain normally, should I have neutrophils? Nope. Normally, I should have a couple of lymphocytes surveilling. That's it. Few lymphocytes, make sure everything is cool. So if I see thousands of neutrophils, it's pretty safe to say it's a purulent bacterial meningitis. Pretty safe to say that. So you want to gram stain it, you want to culture it, you want to try to find out what organism. But remember, you never ever wait for cultures to come back with bacterial processes. You start the empiric antibiotics based on what you think it most likely is and what the gram stain shows. Don't wait for the cultures. Treat, treat, treat. Now, for fun, when there's bacteria, is it going to get hungry to eat glucose? Yeah, glucose, you should love. All right, how about proteins? Well, there's inflammation, proteins leak out, and that's going to create oncotic pressure. So that opening pressure, when you first put the needle in, oh man, very high pressure. It's got the highest opening pressure. But notice, proteins often leak out in all of them. So this is the low. This one could sometimes be like near normal, but they go up pretty much in all of them. And of course, the pressure can go up with all of them. It's the highest with bacterial, but it goes up with all of them. So again, this is not really going to give you free points. What's going to give you free points are these two. You look at the cells and the glucose, and you should know the answer. So when I say lots of neutrophils, it's bacterial. Now, when I say lymphocytes, we have a little bit of an issue here because lymphocytes could be viral, which is aseptic, or it could be due to granulomatous infections like mycobacterium, fungus, one of the atypical chronic bacterial ones. Well, to tell those apart, take a quick peek at the glucose because virus is not living. It's not going to eat the glucose, so it's usually near normal. On the other hand, everything else is hungry, and therefore they're going to eat it. Glucose is going to drop. Now, it also has to do with the inflammation, too, because inflammation will turn on glucose transporters, whereas inflammation shuts down glucose transporters. So if there's a lot of inflammation, glucose transporters don't work so well. So it's a combination of the bacteria eating it and the inflammation shutting off glucose transporters, kind of a combo effect. But that's why the glucose is going to drop. Okay, so 3 points. Don't miss these CSF meningitis findings. All right, now let's talk more about some viral meningoencephalitis. So not just meningitis, now it's actually going into the brain itself. Now, very characteristic lesion. Whenever I have viral infections, usually you're going to see microglial nodules. Microglial nodules, especially around blood vessels. Very common perivascular microglial nodules. That's just common for most viral infections, microglial nodules. Now let's talk about some subtypes. Herpes simplex type 1. In your brain, isn't that a cold sore? Yep, but it can get into your brain. Now, where does it go? If you take a look at this picture, look at this necrosis, this hemorrhagic necrosis bilaterally in the temporal lobes. So that's a very characteristic location. You see necrotizing infections of the temporal lobes. Very characteristic. And under the microscope, it's literally necrosis. I mean, where's the normal brain? This is all liquefied, destroyed stuff. This is all dead stuff. The brain just falling apart. Look, it's all cracking in here. This is all dead tissue. So this is a necrotizing inflammation of your brain. Now, who gets it? It's common in young kids and young adults. That's where we're going to see it. And 10% will have a history of having herpes simplex. They've had cold sores in the past, and now because of immunocompromise, it goes to your brain and causes necrosis. But notice, that means most cases, this is the first incident. So you get it, and it goes right to your brain. Now, again, it's not a very common thing to have happen, but herpes can go right to your brain and give this problem to you. Now, you're going to get changes in mood, in memory, and behavior. PCR can detect it in the CSF, and of course, if you did a brain biopsy, which you usually don't do, but an autopsy, you can see the Cowdrey type A intranuclear inclusions because it's a DNA virus. Now, herpes simplex type 2, this usually is going to give you a meningitis, and that's pretty much in adults, usually adults. Now, it could occur in a brand new newborn from an adult did something with their hands, and then they touched the kid, and the poor kid got it. Because remember, type 2 is usually below the waist, usually down there. So we think of adults with this one, but newborns can get it too from the parents handling them. And again, meningitis is usually what you get. Okay, now what about varicella zoster virus? Well, remember, this is chickenpox, but it can hide in our brain. It usually hides in the dorsal root ganglia, and then it comes back out, and it comes out very painfully as herpes zoster, shingles. All the shingle ladies, all the shingle men. So it usually hides in the dorsal root ganglia. Come back out. Sensory ganglia, it's going to hurt. Now, for CMV, we're going to see this usually in people who are immunocompromised. So classic example being AIDS patient. But question, can it be transmitted as a torch disease to a in utero, into a fetus? Yeah. So it can be a torch infection transplacentally. So AIDS patients and patients who get transmitted from the mom to the baby. Now, where does it like to go? Well, it goes everywhere. But in those torch babies, you're characteristically going to see calcifications next to the ventricle. So watch over periventricular white matter calcifications. That's congenital CMV. Periventricular white matter. So remember the ventricles, and then these look like C's for CMV. So CMV's around the ventricles. Okay, now polio, we know polio, this can cause paralysis. It usually goes to the spinal cord, and it gets the same place as Lou Gehrig's disease. It's going to get those motor neurons in the anterior or ventral horn. So same place as Lou Gehrig. So that's pretty important to know. Spinal cord, motor neurons. So basically, you can stop breathing. They have to put them in iron lungs to keep breathing for them because the nerves don't work, the muscles don't work at all. Now, HIV. HIV gets in your brain. You're going to get what's called HIV encephalitis, which is AIDS dementia complex. AIDS dementia. Okay, so HIV encephalitis gives you dementia due to AIDS. Now, here's the question. What would I see in the brain? Well, in the brain, HIV infects CD4 positive cells. So in the brain, it goes into the microglial cells. Microglial cells, they're the ones who get affected. Now, when they get infected, they fuse with their friends. So when a bunch of microglial cells fuse and fuse and fuse, you get multinucleated giant cells. So that's the key. AIDS patient dies of dementia. What would you see in the brain at autopsy? You're going to see multinucleated giant cells. That's HIV encephalitis, HIV of the brain. Again, did I say granulomas with giant cells? No. If I say granulomas with giant cells, then you want to think about fungus or parasites in the brain. But when I just say giant cells, that's when you're going to think about HIV, encephalitis, AIDS, dementia. And then, of course, rabies. Oh, the board loves rabies. You get bitten by a raccoon or a skunk, or you leave the window open, a bat comes in and licks you, a bat bite, or fox. What does the fox say? Rabies. Now, where does rabies go? Well, it's going to go to your memory site. Where's memory? The hippocampus. So it goes to the hippocampus, and in the cerebellum, it goes to the Purkinje neurons. Purkinje. So these are the classic sites where it likes to go. Hippocampal neurons, Purkinje neurons of cerebellum. That's where it likes to go. And then you'll see inclusions. Because remember, if I'm going to look for the negre bodies, the inclusions, I need to know where to look. You need to look at the hippocampus at autopsy, and you look at the Purkinje neurons. And then you'll see them. You'll see in the cytoplasm. So here is the neuron. Okay, here is the nucleus with its nucleolus. And then here is a cytoplasmic pink inclusion. Remember, RNA viruses are going to have accumulations in the cytoplasm. RNA, cytoplasm. Here's another one. These things are beautiful. Look at the size. They're pink because they're protein, they're viral proteins, and they're in the cytoplasm. So these are called negre bodies. Very, very characteristic. You're going to see the hippocampus and Purkinje neurons of kids that were bitten by bats. That's what we look for. Again, foaming at the mouth, and they hate water, and they die neurologically. You got to get the passive immunization and vaccination done after a bite. So if you have an animal or you can't find the animal, you don't know, you definitely want to get some prophylaxis on here. Okay, do not give the passive antibodies at the same time you're giving the active immunization because you're forming immune complexes. So give them at different sites. Give the antibodies near the bite, and then give the antigen to create, so your immune system makes your own antibodies, give it a distal site. Very good. Or you get Arthur's reaction. Okay, now what about fungus? Oh, she's a fun gal. Fungal infections? Oh yeah, meningoencephalitis. They like fungi in the brain. So here are a couple patterns. Number one, you can get a chronic meningitis. So chronic meningitis, Candida can do that, Mucor can do that, Aspergillus, and Cryptococcus. In fact, Cryptococcus is the most common cause of meningitis in AIDS patients. Most common meningitis in AIDS. Cryptococcus neoformans. Don't forget, when you get the CSF, you want to do India's ink. India's ink to look for it, and then do latex agglutination for cryptococcal antigen. Now, vasculitis. There are two fungi that are angioinvasive. So they invade vessels, and it's going to be very bloody. Those are Mucor and Aspergillus. Mucor and Aspergillus. Now, if you remember, Mucor is usually in DKA, diabetic ketoacidosis. So it's a type 1 diabetic, they're uncontrolled. And then we'll see these broad aseptated hyphae. Notice they're very broad, no septations, and they branch at 90 degrees. That's our friend Mucor, 90-degree branch. Beautiful. Type 1 diabetics, and it usually starts as a sinusitis and then goes into the frontal lobe. You'll see hemorrhagic necrotic lesions in the frontal lobe, and it will kill you. It's lethal. Rhinocerebral Mucor has a high mortality. Now, for Aspergillus getting in her brain, it ain't going to be you and me. It's going to be immunocompromised for both of these fungi. So, and also for Cryptococcus too. So for this one, it's either AIDS patients or anybody with neutropenia. Neutropenia, so somebody who had just had chemo, somebody who had a bone marrow transplant, anybody who doesn't have good immune system is going to be at risk here, especially when it's really low neutrophil. Absolute neutrophil count goes down. One of the bugs you worry about is Aspergillus. All right, now what did it look like? Well, it had 45-degree branching. It was much, much narrower than Mucor was, and had septation, and it was branching at a acute 45-degree angle. So remember, AIDS patients, angioinvasive. AIDS patients, angioinvasive. If you have a good immune system, you'll get anaphylaxis from it. You might, if you had a cavity, you might get aspergillomas, but you're not usually going to have invasion. So it's got to be somebody immunocompromised to get invasion. Now, don't get mad at me. All the board said was, this is a picture of an AIDS patient who dies. That's it. Well, when AIDS people die, they often die of opportunistic infections. Then I look at the picture and I see hemorrhage, 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 hemorrhage. Scattered hemorrhage in an AIDS brain? What infection do we just talk about is angioinvasive? Well, if it's in the frontal lobe, in a diabetic, you'll think mucor. But in an AIDS patient, you want to think about aspergillus. And that was the only clue they gave you. AIDS patient dies. They showed this picture. Hemorrhagic, hemorrhagic, hemorrhagic. Makes sense, huh? Now, what if I saw a large collection of yeast instead of hemorrhage? I saw a large collection of yeast invade the brain. Well, then I want to think about Cryptococcus or Candida because these will actually invade the brain and give me big masses of infectious bugs. So let's take a look at that. So here's Cryptococcus neoformans. It's a very common opportunistic infection of AIDS patients, and it's the most common cause of meningitis in AIDS. So it starts as a meningitis, then it invades the brain. Now, do you see these collections? Doesn't it look mucoidy there? Looks like gelatinous. Yeah, because it's a yeast with a thick capsule. So that's what creates all this clear stuff in this brain. Look at all this stuff. This is just collections of it in the brain. Now, on MRI, this is going to look like soap bubbles. Well, that's not good. Bubbles in your brain? No, thank you. This is bubbles. Now, to diagnose meningitis, we're going to check the CS out. We'll use India's ink to see it. Now, on a tissue biopsy, you're going to do a tissue biopsy to see that thick capsule, that big mucoidy capsule. It's PAS positive, so that's helpful. You see carmine is positive, we'll light it up too, and silver stains, it's a fungus. So you got three things that'll help light it up on the exam when it invades the actual parenchyma. So PAS is positive, you see carmine positive, silver positive. All right, now here's a little bit closer view. Notice, it's really hard to see, but I think you can see this round thing is the yeast. This big clear space around it is its capsule. So again, there's the yeast with the big capsule, the yeast with a big capsule. Man, these capsules are so big, create a lot of clear space. And that's what you're seeing here, all this mucoidy stuff. These are bubbles, soap bubbles in your brain. Now, here will be the question I would ask. How does it starts in AIDS patients as a meningitis? How does it go from meningitis to encephalitis? Okay, well, on the surface of the brain, you've got arteries going along the surface of the brain. So here's the surface of your brain, and then here's the artery. It's the artery, A for artery. Well, how does it bring blood into the brain? It's going to have penetrating artery branches. So the artery is actually going to penetrate into the neuropil. So again, this is our brain, come on. And this is the artery. It's going to have a little penetrating branch that goes into the brain. Well, when the blood vessel enters the neuropil, it's going to bring some of the arachnoid with it. So any yeast that was here, any yeast hanging out here in the meninges, well, they're just going to follow these spaces. They're just going to follow them down. And that's how it's going to get into your brain. It's going to follow the spaces around blood vessels. And this has a fancy name. This is called the Virchow-Robin space. Oh, back to anatomy. How can I make the Virchow-Robin space test? Oh, that's how the fungus Cryptococcus will enter the brain. Very good, very good. It just follows those spaces. Virchow-Robin enters the brain and you get soap bubbles. Bubbles in your brain. Not cool. All right, now let's talk about parasites in the brain. Parasites can cause meningoencephalitis too. And the big one is the cat. Meow. If you take care of a cat, now you can at risk for toxo. Other things can do it too, but cats are the classic one. Toxoplasmosis gondii. This is a parasite. Now, it's a common opportunistic infection in AIDS patients. So again, if you have HIV or AIDS, you should not clean the cat litter. You shouldn't be cleaning it. But it also occurs in pregnant women. Pregnant women shouldn't be cleaning the cat litter either. Gentlemen, it's the least you can do. She's pregnant. She's doing a lot of work. Go clean the cat litter because pregnant women are immunocompromised, and it can go into the. It can be. Remember, it's one of the torches. This is the T of torch, so it can affect the baby in utero. And again, you don't want encephalitis and retinitis in your baby. You don't have a small brain. You'll have calcification in the brain, but this time it's basal ganglia. That's where they like to go, basal ganglia. In fact, here it is. Take a look at this brain. Okay, here's the caudate. Caudate, here's the ventricles, lateral ventricles. Caudate's right next to it. This is the lenticular nucleus of the brain. Lenticular, do you see why they call it lenticular? look like a lens. Yeah, this is the putamen and the globus pallidus. And then notice this abscess here. See this abscess? It's like a well-demarcated mass with kind of necrotic stuff in the middle. The liquid would just pour out of this if you turn it over. This is an abscess in the putamen. Then notice down here in the thalamus, they got a lesion here too. Oh no. Well, this can lead to problems with my pituitary now if you knock out the thalamus. So not such a good thing. So basal ganglia. Basal ganglia. That's where you're going to see these abscesses. Again, it could be anywhere in the brain, but basal ganglia is the most common site, and they'll calcify. So if it's a torch disease, you'll see calcifications this time in the basal ganglia. So newborn with calcification around the ventricles, congenital CMV. Newborn with calcifications in the basal ganglia, now you think about congenital toxo. Now to see these, you're going to see them on an MRI or a CT as a ring-enhancing mass lesion, multiple ring-enhancing masses. In fact, in AIDS patients, it's the most common cause of multiple ring-enhancing mass lesion. Now let me explain what this is before I go forward. What the heck is a ring-enhancing mass lesion? Well, if I do a CT or an MRI, and I see masses in the brain, there's a mass. Okay, but what's the ring-enhancing about? Okay, now we're going to repeat it. And this time we're going to add contrast. When I add contrast, if this is infectious, it's inflammatory, or neoplastic, the contrast will leak out of the inflammation or the tumor, and you'll get a ring of contrast around the mass. So that's what they mean by ring-enhancing mass lesions. I have a mass on CT or MRI, I add contrast. If the contrast leaks out, it makes it enhance, makes a ring around it, ring around the lesion. That usually indicates that it's most likely inflammatory in nature or neoplastic in nature, because contrast leaking out. Now, other things can do it too, but the two biggies, always think ring enhancing for inflammatory, think for it for tumors. That's what you should think of. Now, we have a little bit of, I can make a little cheat sheet here for you of ring enhancing mass lesions. It's basically 5 they like on the exam, 5. Okay, the number 1 is going to be in AIDS patients. Okay, actually number 1 and number 2. In AIDS patients, you have 2 reasons, common reasons, to have multiple ring-enhancing mass lesions. So again, it's a little cheat sheet we're making here. Multiple ring-enhancing mass lesions. Well, the most common cause in AIDS patients of a mass lesion, the space-occupying lesion in the brain, is toxo. Toxo. So always ask, does the patient take care of a cat? Toxo. You can get it from other things too, but toxo is a big from cats. Now, number 2 most likely in AIDS patients is a high-grade non-Hodgkin's lymphoma, usually large diffuse B cell, usually immunoblastic type, so large diffuse B cell, immunoblastic type, very aggressive. It's going to kill them. It's going to kill the AIDS patients. So this is my differential. This is my number 1 and 2 differential. I see multiple ring-enhancing mass lesion in AIDS. So the question will be, doctor, we have an HIV positive patient. They have multiple ring-enhancing mass lesions. What do you think it is? And you're going to say, well, Barone said the most common cause is toxo. Does the patient own a cat? The second most common is a high-grade lymphoma. It's going to kill them. You're going to say, damn, you're good. How do we tell them apart? Had a big differential. That counts for something, doesn't it? Yeah, it does. But how do we tell them apart, smarty pants? Well, you could do a brain biopsy for lymphoma, but that's kind of invasive. So usually what we do is we treat for toxo. We give antibiotics for toxo for 2 weeks. 2 weeks. And then we repeat the CT. If it gets smaller, keep treating for toxo. If it doesn't get smaller, hello, brain surgery? Yes, we need a brain biopsy. It's going to be lymphoma. They're going to die anyway. But we need to confirm the diagnosis before they die. So you'll need a brain biopsy. Make sense? So again, that's how you're going to do this. When you see ring-enhancing masses in AIDS patients, multiple, they would toxo first. They're usually in the basal ganglia. Lymphoma can be anywhere. And again, the cat is helpful for exams, but in real life, can people with cats get lymphoma? No? Let me know. I'll buy a cat. Are they protected against lymphoma? So in real life, the cat doesn't work. Serology would be helpful. If you had positive serology for toxo, that would help. But AIDS patients don't always have good serology. They stop making antibodies. So if serology is positive, that can help. Otherwise, you need to treat. Treat for toxo. If it gets better, great. If it doesn't get better, you do a brain biopsy. Make sense? Now, here's what it would look like on autopsy. You're seeing all these protozoa here. This is, by the way, an immunostain. So on the brain biopsy, we can do immunostaining to look for the toxoplasmosa tachyzoites. So all this stuff that's lighting up, this is the Toxoplasma tachyzoites. And here it's encysting. It's forming a pseudocyst here, starting to make a cyst. So they encysted themselves after a while. But these are the free tachyzoites invading the brain tissue because you got no immune system. Okay, so that's Toxoplasmosa gondii, Okay, now the last of the infectious diseases is a protein. Infectious proteins, these are sexy. This is a group of prion diseases, prion proteins, or prion, I would like to say prion instead. And they call these spongiform encephalopathies because the brain literally looks like a sponge. Look at the holes. Look at the holes in the brain. Because see this neuron here? See, here's the nucleus. Here's the nucleoli. Here's the cell body. Now tell me, most of the cell body's pink, but over here you got vacuolation. You start getting vacuolation of the neurons and their processes, and that's what you're seeing here, vacuolated neurons. Well, they ain't gonna work so good when your brain is holy. So this is called spongiform change, when you see intracellular vacuoles in neurons and also some of the glial cells too. They're not working right if they're all damaged and swollen like that. Now you also see this pink junk. What's this pink junk? Well, this is amyloid protein. Congo red positive, this is amyloid protein. John, doesn't this look like Alzheimer's senile plaques? Yeah, it does. Yeah, senile plaques and Alzheimer's that give you dementia. Well, guess what? These are almost identical. They look like senile plaques, but they're not senile plaques. They do give you dementia, so we have to change the name. We call them Kuru plaques because one form was found in Papua New Guinea where people eat each other's brains, and the Kuru form, they have huge plaques, so they call it Kuru plaques. So these are Congo red positive amyloid derived from altered prion protein accumulating. Just accumulating, making a beta-pleated sheet. When it makes a beta-pleated sheet, we call it amyloid. So it's very similar to Alzheimer's. Alzheimer's has amyloid plaques in the brain, so do the prion diseases, and they both get dementia. Except here's the difference. Alzheimer's, what does it take, 10, 15 years to kill you? Take Alzheimer's, squeeze it into 6 months. That's rapid. Very rapid dementia, that's prion disease. Rapid. It's like accelerated Alzheimer's. Alzheimer's, you get it and die in 6 months. Crazy, huh? All right, now which one will be on your exam? Which prion disease? Well, these are all rare. Kuru is basically wiped out. Kuru is the one that we saw in the Fore tribe in Papua New Guinea. Because what the tribe would do is they would eat the brains of their family. Like when the grandparents died, they would eat the elders' brains because they didn't want to lose the knowledge. And they made the women eat the brain to pass the knowledge on to the next generation. The men had to eat the heart for strength. The women had to eat the brain for knowledge. Well, guess what? There hasn't been a case of this since the 70s because Westerners came there and said, oh, you want to remember the knowledge, the wisdom of the elders? Don't eat their brain. Here's a video camera. Videotape their knowledge and their stories. So there hasn't been a case of this since the 70s. Now in America, any cannibalism? Anybody eaten everything? No. Let's see. We had Jeffrey Dahmer, but he's gone. He's dead. We had Hannibal Lecter, but he's not real. If a zombie apocalypse returns, so will cannibalism. Are you watching The Walking Dead? Yeah, so this could make a comeback if this is zombie apocalypse. And by the way, the zombie apocalypse has officially occurred. I don't know if you've noticed, but people are walking around like zombies. They're walking around looking at their cell phones. I mean, they're like zombies now. They're like attached to their secondary brain. So people are really lobotomized nowadays. It's crazy. All right, now that one's pretty rare. One that's the most common of these rare diseases is this one, CJD. CJD. So this is the one we're going to have to talk about because this is the most common of the human forms. Now for fun, look at this one. Fatal familial insomnia. You never go to sleep and then you die. That sounds like medical school. That sounds like studying for USMLE. That sounds like residency. You never go to sleep and you'll die. No, you'll be able to make it. But yeah, it's crazy, huh? Now, what about sheep? How do you know a sheep is crazy? You can't talk to a sheep. How do you know a sheep is crazy? When they go up to the fence and they literally scrape their wool off. You like that? Sheep just got naked. That's a crazy sheep. So they call it scrapies because they scrape their wool off. Now, what's the one you call in cows? Okay, mad cow disease is what lay people call it. We call it bovine spongiform encephalopathy. That's when the cow go crazy. Now, what if McDonald's doesn't notice the cow went crazy? So they put it in the grinder, they make a hamburger out of it, and they feed it to you. Well, when you get it, you can't call you a cow because you're not a cow. I'm not a cow, you're not a cow. We call it CJD variant. So it looks just like Creutzfeldt-Jakob, but it's going to be younger, and they're going to be eating hamburgers. So it's like the same disease, except it's younger because they get it from hamburgers. All right, so let's talk more about this one, CJD. And again, in all of these, you're going to see spongiform change, holy brains, no wonder you're getting dementia, and you're going to see these amyloid Kuru plaques in all of them. That's a classic uniform finding for all of them. All right, now here's the most common of these very rare human transmissible spongiform encephalopathies, CJD and its variant. Now, it is transmissible. So what does that mean? It's transmissible? That means you can pass it on. Hold on one second. I gotta figure out how to answer this phone. Okay. You can transmit it. So once you get one of these infectious abnormal prion proteins, and notice they abbreviated SC. SC for scrapie, because they found it in scrapie first. But all of these, the bad prion is called the SC1, PRP-SC. Well, it's infectious. If I give you one of these and it gets in your brain, it will take the normal prion proteins, which you already have in your brain, and it will convert them to the SC form. And then they'll start depositing and depositing. It's kind of like a domino. You already have prion proteins in your brain, but they're normal. When this abnormal one gets in there, it converts them, and then it tells two friends, and it tells two friends, and it converts all the proteins into bad ones. And on your brain, you get rapid dementia. So that's like a domino effect. Now, here's your question. How do I transmit it? Could it be a pathologist cutting a brain that he cuts himself? Remember, you have the intimate exposure to brain material. So it could be a pathologist who's cutting a brain and cuts himself, but there's never been a documented case of it in a pathologist. And besides, how would you know? Pathologists are demented already. How would you know that there's any change? It would be hard to detect. So there's never been a case of a pathologist that we know of. Now, here's one. This is a favorite one. Human growth hormone. Nowadays, we make it recombinant. We make it in the lab. But we used to pool it. So if little Timmy wasn't growing, we would go down to the morgue, get a bunch of dead body pituitaries, we just grind it up and concentrate growth hormone. Well, guess what? What if one of those cadavers, we thought it was Alzheimer's, but it was misdiagnosed. It was a rapid prion disease. It was like, they thought it was fast Alzheimer's. Or maybe they got in a car accident. They never developed symptoms. Well, now you're going to take that, grind it up, and you're going to give the kid growth hormone with prion disease. Now, the incubation period is a long time. So it may take a long time to get to your brain. But once it gets to the brain, you're going to get rapid dementia. So what they may tell in the vignette is, 15 years ago, he had growth hormone. Because in the old days, we used to pool it. Nowadays, we don't do it anymore. But 50 years ago, he had growth hormone as a kid, and now suddenly he gets a rapid dementia and dies in 6 months. That's Jakob Creutzfeldt because of the growth hormone he got in the past. Now, another one is neurosurgery. Neurosurgical instruments. If I use them on one brain, then I sterilize them, and I use them with the next brain, you just passed it on. Because standard sterilization with standard flash autoclaving, high temperature steam, but it's only, you don't do it for like 15 minutes. For most surgical instruments, that's all you need. Neurosurgical instruments, you need longer, because these are very stable prion proteins. To break them down, Form 1 doesn't work. You have to use either special chemicals or autoclaving at high temperatures for at least an hour. So that's why neurosurgeons get their own operating room, and all their instruments are kept separate from all the other instruments. Because the other instruments get flash autoclave. For the neurosurgical ones, they put them in special chemicals, and then they do autoclaving at high temperature for about an hour. Yeah, so very important. In fact, what happened, I don't know if you read in the news, it was like, last year, they actually shut down a program for a while to figure out what happened, because a couple of patients started getting CJD. They're like, what happened? And they traced it back What happened is one of the new guys who started in the OR didn't know he had to keep the genes separate, and he mixed them up, and he flash autoclaved the ones for the neurosurgery. He didn't do the high temperature long term one, and unfortunately, they wound up spreading it. Isn't that terrible? So you went in, you had a brain surgery, and now you're fine. And then 10 years later, they call you up and say, oh, a couple people in the same time frame also got this disease. You might have gotten it too because they didn't clean instruments. Whoa, that would be horrible. So needless to say, they shut the program down to figure out what the heck happened, because that's a big lawsuit. That's not good. And then finally, corneal transplants, because your eye is an extension of the brain. So if I go down to the morgue and I take a dead body donor cadaver pituitary, a dead body cadaver cornea, and I transmit it to a living patient, well, what if that donor, we thought it was Alzheimer's, but it was prion disease, it was misdiagnosed, or maybe they just didn't have symptoms yet. Well, now you're going to transmit it. You're going to transmit it. So again, this is very rare, but these are the classic scenarios: growth hormone, neurosurgery, corneal transplants. That's the ways we've known it's been transmitting. Now, when you get it in your brain, it may be a long time to get to your brain. It's going to have to actually get there. But once it gets there, you get rapid symptoms, and that's really the key. So it starts out subtle changes in memory and behavior, and then it goes rapid, because it's like a domino. Once it builds up speed, Steve, that's it. So rapidly progressive dementia, and that's the key for the vignette. Look for rapid dementia, and they get these involuntary jerky muscle contractions when they're surprised. So if you go and he's fall asleep, you get this startle myoclonus. It's very classic for this disease, this jerking contraction when they're suddenly stimulated. Startle myoclonus, very characteristic. They can also get involvement of cerebellum, so they can get ataxia, but that's not a very common finding. But ataxia can occur. Now, EEG is very important. You're going to see periodic, sharp, these spiking waves, these just abnormal discharges. It's almost like epilepsy. So very periodic, sharp waves, these are very characteristic and helpful for diagnosis. Because remember, I don't want to open up your brain and expose everybody to this. So I could do a brain biopsy, but we'd rather not. So EEG, clinical history of the rapidity, plus an EEG, and then look at the CSF. If these neurons are dying rapidly, they're going to release 14-3-3 protein. So let me repeat, this is a marker of rapid neuronal death. Is it specific only for the? No. It's just a marker of rapid neuronal death. So if you just had a stroke, this will go up too. But if you have a rapid onset of dementia with the characteristic EEG changes, you check the CSF and this is elevated, that kind of cinches the diagnosis without having to do a brain biopsy. Again, I can always confirm with a brain biopsy or confirm it absolutely without autopsy. You'll definitely confirm it. But I don't want to usually expose anybody to brain tissue in this disease. So history plus EEG plus CSF, look for protein 14-3-3. Now I should have made it red because they're asking it quite a bit and students don't seem to know it. So I got to make this silly so you remember it, okay? So do you guys remember Christopher Columbus discovered America? And to remember what year it was, they had like a song, Christopher Columbus sailed across the sea in a certain year. Remember that? Well, I'm changing the song. I'm going to change the song to, in 1433, Jakob Creutzfeldt sailed across the CSFC. So I'm just changing that silly song to help us. Okay, so in 1433, Jakob Creutzfeldt sailed across the CFC. So seeing elevated 14-3-3 protein in the CSF with the proper EKG and history, that can help confirm this diagnosis. And again, the other key is it's rapidly fatal. The average survival after getting the symptoms is usually 7 months. Most people are dead between 6 months and a year. You don't live very long with this disease. Not a good thing to have. All right, now, how do you get it? Well, you already have this prion protein in your brain. You already have it in your brain. So the prion protein, PR prion protein, that's what we call PRP, but the normal configuration is an alpha helix. It's a nice alpha, that's normal. That's what should be in your brain, a nice alpha helix. Now we call it PRP-C. C is the politically correct form. So it's a PC, politically correct. That is the proper form. So you already have this prion in your brain. It's normal. It should be in your neurons. Your neurons need it. It's a prion protein, but it's an alpha helix. That's most of the configuration. Alpha helix, that's good. So when does the good girl go bad? When she turns to a beta-pleated sheet. So it goes back and forth in these sheets now. That's bad. It gets mostly a beta-pleated sheet configuration. Now we call it PRP-SC. SC again for scrapies, because they found it in scrapies first, but they all have it. Okay, so PRP-SC is just the beta-pleated sheet form. Now, tell me why this is bad. Tell me what you know about beta-pleated sheets. What do you know about beta-pleated sheets? Amyloid. So when it turns to a beta-pleated sheet, it's going to deposit as amyloid Kuru plaques, those Kuru plaques, and give you dementia, just like Alzheimer's. Remember, Alzheimer's had amyloid plaques giving dementia. This has amyloid plaques giving dementia. We just call it Kuru plaques because it's a different protein. It's prion protein. In Alzheimer's, it's beta cleavage of the amyloid precursor protein. BAP, 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 gives you dementia in Alzheimer's. So this is prion protein. So this would be called amyloid PRPSC. That's what we'll call this amyloid. And again, it's very hard to break this stuff down. It doesn't want to be broken down. So formalin doesn't kill it. Standard autoclaving doesn't kill it. You have to use special chemicals and autoclaving at high temperatures for a longer period of time. Now again, it's going to be conjugate positive because amyloid is always positive. So how does it go from an innocent alpha helix to an evil beta pleated sheet? How does that occur? Well, it could be spontaneous. Just bad luck. Just bad luck. One of your alpha helixes turns to a beta pleated sheet, then it turns on everybody else. Or it could be hereditary. About 10 to 15% have mutations in the gene for the prion protein. So that's hereditary. Now, how much does that suck? You're born with a mutated beta pleated sheet? Well, it's only a matter of time before your brain gets dementia. It's like a ticking time bomb. But the one the board loves the most is the sporadic cases where you get it infectiously. Sporadic infectious cases, you get it from somebody else. So again, a small number are just sporadic change. 10 to 50% are hereditary, but the majority of cases are sporadic. They're infectious, from corneal transplants, from growth hormone, from getting it from somebody else. And that's how it goes from good to bad. And here's what it does. All you need is one beta pleated sheet to make it to your brain, because the beta pleated sheet form causes a conformational change of the normal alpha helix into the beta pleated sheet. It converts the good girls, makes them go bad. So it's kind of like this. Here is the normal prion protein that's in your brain. It's nice wild type. It's perfect. Once it gets converted to this beta pleated sheet, now you got trouble. So either it gets mutated, so hereditary, or spontaneous, or more likely you get it from somebody else. You would get inoculated, maybe eat a hamburger, a mad cow burger. Once you get one in your body, now it goes to the normal ones. This is the alpha helix and turns it into a beta pleated sheet. See what happened? It went from alpha to now beta. Now these two guys will go find two more and convert them, and then two more, and then so on and so forth. So it starts out with one, then it doubles itself, then those two will get two more, then those four will get 8 more, then those 8 will get 16. It's like a domino, man. After a certain period, it's all over. It's kind of like the Matrix. Do you remember the Matrix? Where Agent Smith, he starts duplicating himself. He just goes up and now you're Agent Smith, and then now you're Agent Smith. That's exactly what's happening here. It's like the Matrix Agent Smith. It's just converting one to the other. It's kind of like pimping. It's like pimping. I'm the evil beta pleated sheet. You're the innocent alpha helix in the brain. Come here, innocent alpha helix. Come here. Now you're working for me. You're a beta pleated sheet. Now I'm going to pimp you out. Go get more. Yeah, it's like pimping. But you're not pimping the hose. You're pimping the proteins. I'm sorry. It's hard for a pimp. We get no respect. All right. And this is the accumulation that turns to amyloid. And amyloid squishes all your neurons and basically causes dementia. All right, now we can switch gears and talk about another group of diseases. So again, perfect time to end the tape. We'll come back, we'll talk about malformations and developmental disorders. See you on the next tape.